everybody, Dr. Deed Harrison here of Chiropractic BioPhysics Seminars and Chiropractic BioPhysics Nonprofit, our research foundation. If you've been following our YouTube videos, you've watched several of the research videos that discuss the key aspects of each one of our peer-reviewed publications for Chiropractic BioPhysics Nonprofit. This particular video is going to be our 49th video. I'm excited to say that we're recently updating our CBP Nonprofit website. Originally, we had 154 peer-reviewed publications on that website, and this is a brand new table that you'll see. We're actually up to 190 peer-reviewed publications that are either already in print, currently in press, and then a handful that are in review. So I just want to go through this updated table with you because holy cow, it's a wow. If you look at this, this is the list of journals that we've been in, 1 through 21, and these are what we call PubMed journals, which is the majority of our peer-reviewed publications. If you look at this, we've been in journals from the Archives of Physical Medicine and Rehabilitation all the way down to Spine and the Spine Journal. And then of course we've been in many chiropractic journals that may not be indexed on PubMed, but they certainly are peer-reviewed. They're indexed on Mantis and CINHL. This particular category of journals is very important as it's primarily the chiropractic impact and chiropractic professional education. And then we've been in 12 conference proceedings that are not yet published. So if you look at our list, we have 183. 12 of these are in conference proceedings that we're still working on the submission process. That leaves us with 172 actual peer-reviewed publications as of right now, and then 5 are in press at different journals. That's 177 papers that are accepted or printed already, and then in review we have 12 more. So we're really making a strong push. We want to get to the 200 mark with CBP nonprofit publications, and then we'll keep going from there. We can only do that with the public support and the chiropractic community support, specifically chiropractic biophysics doctors. We are an evidence-based system and technique. That brings us to the 49th presentation. This one comes from 2003, the journal Spine. This is our Thoracic Kyphosis elliptical model, an idealized model. The title of this project is "Do Alterations in Vertebral Body and Disc Dimensions Affect an Elliptical Model of the Thoracic Kyphosis?" And I'll give you a background on this as we progress. This was done by my late father, Dr. Don Harrison, myself, Dr. Deed Harrison, my dad's former PhD advisor, and our great colleague, Dr. Tad Yannick, Dr. Renee Caillé, the MD, and then Dr. Jason Haas, a CBP instructor and chiropractor in Colorado. This was in Spine 2003, volume 28, number 5, page 463 to 469. It's a fitting topic to do during this week. It's late September, and in just a few weeks we have the 39th CBP annual conference that's going to be held down in Phoenix, Arizona at the Wigwam Hotel. We are going to be focusing on the thoracic spine in health and disease, and we have some major presenters there. We have what I would call the world-renowned Dr. Deborah Cato. She's an MD and a brilliant researcher and educator. She has agreed to be our keynote speaker. She will just absolutely blow you away with her knowledge and her research that she's done with her team on the thoracic spine and how this impacts human health and human disorders, specifically in the senior citizen population, but also in younger populations. Then we also have a radiobiologist, a PhD, that will be covering key aspects of radiation hormesis. Is it risk, is it harm, or is it none of the above? And I'm sure that if you know me, you know where I stand on this, and you're going to hear from an expert in the field that's going to talk about radiation risk and relevance, the risk-benefit ratio, and in fact, we're going to say that it certainly is on the benefit aspect of the curve. So we're excited to bring you the 39th annual. There's many more speakers there, and there'll be some clinical data and clinical presentations as well from CBP doctors, and hopefully some of you will join us there. To this week's presentation, first and foremost, I want to give you just a general background. Now, here's what we know. The thoracic spine in certain specific populations plays a major role in human health and disease and human performance. Not just in the elderly population, but we're going to talk about a couple subjects or a couple studies that focus on senior populations. For example, this project that came out in the European Spine Journal 2014 in a middle-aged and elderly population. This is a prospective cohort looking at shoulder dysfunction relative to the alignment of the thoracic spine and full spine in the sagittal plane. Now, here's what these authors did. They took 317 prospective subjects, 114 men, age 67 years of age, and obviously the rest were women, so 203 women. Sagittal curves were measured via x-ray, grip strength was assessed, back muscle strength using extensor muscle strength, and also shoulder mobility and abduction and anti-flexion. So what was identified is that an increase in the thoracic curvature and spinal inclination, meaning forward sagittal balance, I'll show you a picture, and weak muscle strength in the extensors were identified as risk factors for shoulder problems. Each one of these three things were relevant risk factors that carried an odds ratio for having altered shoulder function. So as we age, a lot of people suffer with, hey, I'm losing the mobility in my shoulder. It's stuck, it's stiff, it hurts. I can't raise things up, and I can't bring my shoulder to the side. A lot of people can't even get their arm or their hand to the height of their shoulder like this. Well, the reality of it is there's multiple causations of limitation in shoulder movement, but a major one is the alignment of the spine in the sagittal plane. Specifically, in this project, anterior translation of the upper portion of the thoracic column relative to the sacrum that they called a displacement of the sagittal vertical axis. This is statistically associated with problems with the shoulder mobility. So your thoracic curve is increased and your spine drops forward. This creates a tension length problem, and it alters the lever arms of the shoulder movers. It also alters the cervical spine, which is then connected to the shoulder movers as well. So we're seeing that the sagittal profile balance plays a huge role in limitation of shoulder movement. Also, increase in the thoracic curvature as measured with the Cobb angle was associated with problems with shoulder mobility. And then, of course, let's not forget the weak back muscle extensor strength. Now, that is obviously tied to the alteration in thoracic kyphosis and in thoracic balance. The key from this paper is, you know what? This is a major problem with people in today's population. If we lose the mobility of the shoulder, we lose the ability to function in some of the activities of our daily life. Also, it's not just an increase in the thoracic curve we have to worry about. Reductions in the thoracic curve can create problems. This is a prospective longitudinal study that came out in 2008 by Kobayashi et al. Flattening of the sagittal curvatures as a predictor of fracture, out of the journal Osteoporosis International, 2008. Now, here's what they did. They took 100 prospectively selected subjects and then followed them for 12 years. Now, these subjects did not have pre-existing fractures. They had an assessment of their spine via x-ray, and then they looked at risk factors that may or may not predict future fracture down the road 12 years later. What they found will shock you. At least it shocked me. If it doesn't shock you, then you know what? I think that you're not even paying attention to this issue. Number one, vertebral fractures are a huge problem in today's older aging population. You get a fracture, you're at risk for another fracture. You're also at risk for very, very severe dysfunction, and you're at risk for early death when you get a fracture. So fractures will increase the thoracic curve and then increase the probability of future fractures and then increase the probability of impairments in your activities and future mortality that will be sooner than counterparts your same age and sex that do not have fracture. Here's what they identified in this 12-year follow-up study. Using univariate modeling, univariate means one thing at a time, a decrease in the thoracic curvature by at least 1 standard deviation carried a relative risk of 3.06 times. What that means is you're roughly 3 times more likely to get a fracture when you have a reduction of your thoracic curvature by 1 standard deviation. Now, what is a standard deviation in this project? Well, the mean thoracic curvature in this population was 24.5 degrees. The standard deviation is 7 degrees. So we're talking a 7-degree loss of the thoracic curve in these subjects carried with it a relative risk of just over 3 times the probability of a future fracture at 12 years when no fractures existed. Now, here's the scary part. Multivariate modeling. When I combine both 1 standard deviation loss of the thoracic curve and 1 standard deviation loss of the lumbar curve, the relative risk jumps up over 8 times, 8.64 times. So losing both of your sagittal plane curves carries with it a huge relative risk, right? But right now we're talking about just the thoracic curve. You lose your thoracic curve, you will lose the ability of your spine to attenuate shock. So shock attenuation is very important for basically dissipating and transferring load throughout the spine, throughout the soft tissues. You lose your thoracic curve and all the shock goes right into the vertebral bodies, and that's where the fracture is likely coming from. Very important project. So those 2 background projects give us basically the need to develop an idealized model for the human thoracic curvature. We've got to be able to compare subjects to normal data and to an idealized subject-specific optimized model that is a validated model. We also have to understand the limitations of this model. Now, just to give you a little more background, before this project in 2002, we developed an average-based subject model. What we did is we took 80 subjects that were optimized just based on lack of pain and a normal exam. We didn't optimize them based on full spine alignment and sagittal balance, which we know from this previous project that I just went through with you in 2014 in the European Spine Journal, alteration in sagittal balance impairs shoulder mobility. So this previous project that we did in 2002, we didn't really optimize the subjects for sagittal balance. What we did is we looked at their alignment and we said, let's see if we can develop a thoracic model based on these 80 subjects' data points. And indeed, we developed an average-based model with segmental angles and with a model that was an elliptical model of the thoracic kyphosis. The elliptical model went from T3 to T10, T2 to T11, or T1 to T12, and we noted an increase in the mid and the upper thoracic curvature and a flattening in the lower thoracic curve. And we got data from these 80 subjects. So the 80 subjects' data is shown here, segmental angles of curvature from T1, T2, all the way down to T11 and T12. The problem with 80 subjects is, in this population, because we didn't optimize their sagittal balance and the rest of their spine, we have some missing information in terms of, are they really an optimized upper thoracic curvature population? Could we actually fit the cervical spine to the upper thoracic spine in our models? We didn't have the ability to do that for a couple reasons. Number one, these subjects did indeed have some alteration in their neck curves. These subjects, we had an inability to accurately identify the upper thoracic segments. So what you'll notice here is that the standard deviation is larger in the upper thoracic curve segments as compared to the mid and lower, and our model or our data doesn't really match an elliptical model where I have an increased rate of curve in the upper segments in these 80 subjects. So we do have some limitation from this population. However, what we're going to do is we're going to take a subset of those 80 subjects in this project. We're going to take 50 of them, and we're going to be more careful in who we select. We're going to select subjects that we can actually see the upper thoracic segments. We're going to select subjects that don't have an alteration of their sagittal plane profile and the sagittal balance. So we're going to weed out people that have the forward inclination of their trunk, like the European Spine Journal study, or a backwards inclination of their trunk. We're going to optimize the sagittal alignment and then get 50 subjects and see what kind of data we can get, and then develop develop an optimized elliptical model that not only fits these subjects, but also fits other data in the literature, and we'll talk about what we did in this paper. So here's what we're going to do. We're going to try to develop a simple but rigorously defined model for the shape and magnitude of the segmental contributions of the thoracic curve. This has not truly been done in the literature prior to this time. Our study approach is to determine an optimized model of the thoracic curve in the least squares error sense. Minimize the least squares error per point from our model to actual digitized points on the 50 subjects data, and to see how closely this model actually represents normal data and data in the literature in general. Okay, so what we did is we took a subset of our 80 subjects, we got 50 subjects, 12 females, 38 males. Volunteers signed informed consent, and this project had IRB approval. The average age is a bit younger, 28.1 years, with an SD of 6.2. The average height is 175 centimeters, average weight is 77.8 kilograms. And what we did is we digitized their vertebral body coordinates using a sonic digitization system, and this system would input their X, Y, and Z coordinates into two-dimensional space. Then what we could do is we could pass different geometric shapes through their digitized points along the posterior vertebral body margins. So we digitized the four corners of the vertebral bodies, we digitized the disc space, and then we could look at best fit elliptical modeling. We used a best fit ellipse that was sectioned into different model partitions using 4 sets of data existing in the literature and from our data itself, and I'll explain where we got this. And then we also had to develop math to be able to calculate the segmental and total angles of curve based on our elliptical model. So in our subjects, we could look at their segmental angles quite easily, but in our model, we had to develop original mathematics to calculate tangent lines to an elliptical curve. That math had never been reported before. So first and foremost, just a quick background. If I have anterior and posterior translation, we know from earlier data that we've done that posture in the sagittal plane will indeed affect the magnitude of the thoracic kyphosis. So not only does the posture itself create a problem with function and mobility in the shoulder and function of the human in general, it actually alters the thoracic curve. So in this project, we said we do not want subjects that have anterior translation that is over a certain amount, and we don't want subjects that have posterior translation over a certain amount. So what we did is we looked at our mean and standard deviation, and anybody that was over that, we excluded them. We said, you know what, number one, it's not healthy for them. Number two, it alters the thoracic kyphosis. And we did that in our earlier project in the European Spine Journal. In fact, we showed that anterior translation will cause a net decrease in the thoracic curve of 13 degrees when you translate forward, and a net increase when you translate backwards. So in our mind, this is part of the reason there's such a wide range of thoracic curvatures in the population. It largely has to do with their thoracic balance. So if we normalize people for their balance, we can get a more normal alignment of their thoracic curvature. If you don't agree with that, too bad, design your own paper. This is what we did, right? So just talking to you about the methods. Also, what we looked at is we wanted to make sure these people did indeed have optimized balance. So what we looked at is the alignment of their T1 centroid, that's the geometric center of the vertebral body of T1, relative to the geometric center of the vertebral body of T12. How closely do these line up? And then how close does that line up with the geometric center of S1? So T1 over T12 over S1. Are these subjects really an optimized sagittal balance group? Indeed, we found they were. These subjects had T1, T12, and S1 vertically aligned with their mean average value 2.3 millimeters off. So we know that we have a very, very strictly defined sagittal plane alignment in these populations. So we've got 7.2 millimeters, 7 millimeters, and 4.9. That's T1, T12, and S1 relative to a pure ideal vertical. So these subjects are really close to optimized. So to us, that meant we can actually look at their thoracic kyphosis data, and more specifically, we can get better data in the mid and the upper thoracic curvature. So to get further into the methods, from observation and upright stance, we decided that the semi-minor axis of the ellipse, that's the short axis of the ellipse. An ellipse has a long axis and a short axis. So the semi-minor axis is this short axis, and we divide it by 2 and we get the geometric center. And then we have the semi-major axis that runs horizontal in this case. So we have a short axis and a long axis. We looked at upright stance and we said that the short axis should pass through, theoretically, the superior end plate of T12 vertebra, and the semi-major axis should be parallel to the back of the vertebral body margin of T12, assuming idealized anatomy. This would then create an ellipse that took up slightly less than a full 90-degree quadrant. Using the posterior vertebral body margin, posterior superior body corner of T12 as a starting point, elliptical models were then attempted for the following: T3 through T11, T2 to T11, and T1 to T11. And actually, this should say T3 to T10. That's a typo, sorry about that. So T3 to T10, T2 to T11, and T1 to T11. That gives us a full spine starting position there. Both a 3-parameter and a 4-parameter approach were used. In the 4-parameter approach, the major and the minor axes, their lengths, so how long these things are in millimeters, were allowed to vary. And then the intersection of these on the XY intersection were also allowed to vary. So we call it a 4-parameter approach because we have 4 variables. We have the length of the major, we have the length of the minor, and then we have its 2 XY coordinates in 2 dimensions. So we have 4 variables. In the 3-parameter approach, we fix one of the variables and we let the other 3 kind of go in space with this elliptical modeling program as it goes through its roughly 1,000 iterations. The paper is actually very heavy in mathematics. My late father and his advisor, Tad Yannick, PhD in math, they had to develop unique mathematical equations to be able to do this project. I'm not a mathematician. I don't have a PhD in it. My eyes gloss over just like yours. But what I want you to know is, in order to determine the segmental angles along the best fit elliptical model, like what are the relative rotation angles in our optimized ellipse, we had to perform original mathematics to take the inverse computation of elliptical integrals. And we had to write original code for this. Now, the paper is so involved that it took several PhDs to actually follow the project when we submitted this to review. And that was one of the actual quotes from the reviewers. The mathematics in this are not very easy. You have to have basically it's PhD graduate level math to be able to follow what's going on, or graduate level mechanical engineering. So in order to develop these segmental angles, the original math equations were utilized and then programmed into a computer. And then to indicate the generality of the elliptical modeling, we took partitions of the best fit elliptical arc and we obtained 4 sets of data. 4 sets of data along the individual partitions would be my relative rotation angles. The problem is, the size of the vertebral bodies and the size of the discs might in fact affect those relative rotation angles in the thoracic spine, unlike really the rest of the spine. Now, the reason we do this in the thoracic spine and we didn't do this so much in the lumbar and the cervical spine is twofold. Number one, we have 12 vertebrae in the thoracic spine. These 12 vertebrae, there's likely going to be a big difference at T12 relative to T1 in the height of the vertebral body, and also the height of the vertebral disc at T1 versus T12. Because it is such a large segment of the spine, we're likely going to see some very large differences as I move from T1 down to T12 in the vertebra and also the disc. So for those 2 reasons, we didn't know exactly what was going to happen until we looked at 4 sets of data. What's the average data in our 50 subjects for their vertebral body heights and their disc heights, what's the average ratio of the vertebral body to the discs, what's the average in the literature in anatomical studies that are reported, and then what if we just develop an optimized model that accounts for a rough estimate of the size change in the vertebral body and the discs as we go down. So we have several approaches that we're going to look at here, and we're going to see, does this affect our data, our outcome of segmental angles when we look at our elliptical model. So to give you an idea, here's our 50 patients. The vertebral body height of T1 is 17.5 millimeters. If you go down to T12, look at the vertebral body height, it's now 28 millimeters. That's a big difference. You cannot say that's a uniform model. So we did develop a uniform model to see, will this affect our data? And we'll see what happens. So here is our uniform model. We took the mean value of these thoracic vertebra, 21.5 millimeters, and you can see at every level we used 21.5 millimeters for the vertebral body. And then we took a mean vertebral disc height to body height ratio of 4.3. So this is what we called a uniform model. We kind of intuitively thought it was wrong, but we didn't know what it would do to the segmental angles when we plugged that into our math equations. So we're going to look at it anyway. Then we plug our subjects in there. We plug our vertebral body heights, our disc heights, and we get a ratio at every level. So we actually plug our subject-specific data in there. And then we look at what we developed, or what we called a uniform increasing model. So this uniform increasing model, what it does, it estimates the rate of change of T1 vertebra down to T12 vertebra and the rate of change of the vertebral body disc. So you'll see the disc ratio is changing relative to the vertebral body size here, and that's what the ratio is. Excuse me, in this uniform model, we assume that the vertebral body is 5 times the height of the disc. In this increasing rate of size change model, we assume that it starts at a 4.4 ratio. Vertebral body is bigger than the disc, or vertebral body divided by the disc, and then we go all the way down to a 5.7 vertebral body to disc ratio. So the disc to body ratio is increasing in a uniform rate as we move down, and what we wanted to do was plug this into data. So for an example of what we did, when we partition our elliptical model based on an idealized 5-to-1 ratio of body to disc height. So we just take an optimized ratio and we plug it in. This is what it looks like. So I have 1/5 here for the disc, and then I have 5/5 here for the vertebral body. I have 1/5 and then 5/5. And if you go all the way up, you'll understand what we're doing by this. We're sectioning each vertebra as a 5 and each disc as a 1, and we develop a ratio. And then we can segment this out and calculate our segmental angles. We did this for each model that we developed, the uniform increasing model and then the uniform model itself, and then we looked at our normal subjects. What we again identified is it was very difficult to model the upper 2 segments of the thoracic spine for reasons we've already determined. It's difficult to see that area. In some of these subjects, they have an injury to the lower cervical spine. It affects it. And then the primary issue is I can't really see to digitize it. But if I look at T3 and T4, you'll notice right away that the uniform increasing model has a better data fit to the actual normal subjects. So when we looked at this, we thought, while the uniform model itself, the 5-to-1 disc to body ratio, is pretty close, no subject is really a 21.5 millimeter height of the vertebral body and perfectly a 1-to-5 ratio of their disc to vertebral body. So we felt like the uniform model was a better representation of actual subject data. And this is really close to our 50 normal subjects. The data is really darn close. The T2 to T11 global angle, normal subjects came out 45 degrees. The uniform increasing model came out 49 degrees. And we've talked about why that would be problematic at the T1, T2 area and the T2 to T3 area. But then when we go to the T3 to T10 model, you can see the subject data 37.4 degrees and the uniform increasing model, how we change the disc to body ratio in a uniform manner moving from T1 to T12, it's spot on with our absolute rotation angle at T3 to T10. So this is the model that we chose. We chose our uniform increasing rate of change in the vertebral dimensions and the disc to body ratio. And we identified that our height over length ratio was 0.96. So when I divide the height of the column by the length of the column, we get 96%. Our least squares error per point is 0.92 millimeters. What does that mean? That means from our ellipse, relative to each point on the posterior vertebral body margins, when I square that, I get 0.92 millimeters. That's actually at the threshold of error when I do digitization. Okay? And then we're a 72.3 degree angle that our ellipse subtends in a 90-degree quadrant. So what we've done here is we've developed an optimized subject elliptical model that fits the posterior body margins, and we've developed an optimized uniform increasing vertebral body to disc ratio that actually fits normal subject data really, really well. In fact, as good as our ability to digitize these points in a computer system. So the fit is actually excellent. Just to show you our data further, table 3 shows our data that I was just explaining there, our segmental angle of our 50 subjects, our uniform increasing model, our uniform model, and then data from the literature. We took vertebral body and disc dimensions from anatomical studies in the late 80s and 90s by Punjabi et al., and we plugged that data into our model to see how that would affect the segmental angles, and then we looked at other data in the literature on normal healthy subjects, and we find out that our model, our uniform increasing model, actually fits data very, very well. So we're pretty happy with this particular model, with our data set, and with the way we approached the problem. Now, the issues in the discussion that I want to touch on are how applicable are this model to the, or is this model to the general population? Well, number one, we know that really large changes in anatomy and architecture of the vertebral body and the disc, is that going to have an effect on our model and our relative rotation angles? Yes, it is going to. However, it has to be relatively large architectural changes, because the data that exists in the literature that we were able to pull from show that it's a very small change. Even the uniform model that we showed, even the data from Punjabi that we showed, they're all very close fit to our uniform increasing model that we developed. So it has to be quite large changes in thoracic vertebral body architectural dimensions. But yes, in those subjects that have very strong wedge angles in their thoracic curvature or in their thoracic vertebra, that will affect the magnitude of their thoracic kyphosis. We do know that, and other studies in the literature do exist. So that's point number one. Point number two is we know age will affect the magnitude of the thoracic curve. In young samples below the teenage years, so we're talking about children under 13 years of age, there will be a change in the thoracic magnitude of the curvature. So I'll have a reduction in the thoracic kyphosis, sometimes by up to 25%. So we know that pediatric evolution of the curve is important. So our model will apply to 13-year-olds on up to how much? Well, we know in the literature this. Once you hit the 6th decade of life, so at 60 years of age, you start to show an increase in the magnitude of your thoracic curve. And that's the project I'm about to explain to you. I'm going to summarize this concept right now, though, before we look at this study. I have an increase in the magnitude of the thoracic curve once I get my 6th decade of life. That increase is roughly a 10-degree increase in curvature, and I get anterior sagittal balance. So I want to stop right there. Number one, you could use a cutoff of 60 years of age and say, okay, 13 to 60, our elliptical model will fit the population very well, assuming they have reasonably normal distributed architectural anatomy of their thoracic vertebrae and discs. It will fit 13 to 60 years of age. Above 60, you can say, well, there's an age trend where I increase the curvature by 10 degrees and I have an increase in the net thoracic kyphosis. The problem is that increase in thoracic curve may not be good for you. Just because something occurs does not mean that it is good for you. I'm now in my mid-40s and I am actually having problem with my eyesight for the first time in my life. First time in my life, I'm having to hold things out at a distance. When things are close up, they're a little blurry. I take my fish oil, I take my B vitamins, I get my eyes checked, I do the right things, I get adjusted, but you know what? I'm starting to lose a little bit of my vision. While it may be normal, I don't like it. I don't want it. I don't think it's healthy. I don't want it to happen to me. If I could do something to stop it, I would. I'm going to try some things. It's just like the thoracic curve. Just because it occurs in a 60-year-old does not mean that it's good for you. It may, in fact, impair shoulder mobility like we talked about, right? So when you see data in the literature and you go, well, in the 6th decade of life and up, the thoracic curve increases and the sagittal balance goes forward, I think you need to look at that as your spine is failing under gravitational and postural loads. It's starting to give way to you going in the grave. Maybe you should do something about it. That brings us to the 2006 paper by Schwab et al., where they nicely categorized subjects based on their decade of life. 21 to 40-year-olds are back here in this nice dark line. 41 to 60-year-olds are in the dotted line in the middle, and then over 60 years old in the dashed line here. You can see the 60-year-olds have a net increase in their thoracic curvature by at least 10 degrees, and they have an anterior translation of their thoracic column. T1 is going in front of T12, and their sagittal balance is really dramatically changing. This may be, in fact, causing shoulder impairment problems and other health disorders. So while it occurs, I'm going to say I don't think it is normal in the sense that it's good for you. It's normal in the sense that it does occur in older subjects in the population. Okay? So let's keep that in mind. So our model, who does it apply to? I think it applies to 13 to 60 and even 60, 70, and 80-year-olds. Although you may never get an 80-year-old back to our idealized model, you need to stop them from progressing to where they go too far with their thoracic curvature. There's many studies that show what an increase in the thoracic curve will do. So our elliptical model, we put that on an x-ray, and we have proper sagittal alignment, sagittal balance, where the top T1 or T2 or T3 lines up with the bottom T10, T11 or T12, whichever vertebra you can see. In this case, we're using T3 to T10. So we put this optimized ellipse down, and then we compare a subject to it. Now the subject in the first x-ray, the middle image, that is quite a healthy, normal subject. We wouldn't say that that is abnormal. But we compare them to a subject here, and we see right away that this adolescent has a pretty strong problem, or a pretty significant problem in their thoracic curve. They have a strong increase in the thoracic kyphosis, and they have a net translation of their thoracic spine posteriorly, and then they have a flexion of the top T1 relative to the bottom T12. This is not a healthy configuration for their thoracic curvature. In fact, this thoracic curve is 55 degrees, and it should be down in the 30s. So we're going to say this model is useful to identify who fits an optimized thoracic configuration, who is within normal limits, and who is outside normal limits, requiring intervention at reducing their thoracic curve, or in other cases at increasing their thoracic curvature. Conclusions from this project. The mean thoracic kyphosis digitized on lateral radiographs of 50 healthy patients from a subset of 80 was closely modeled with a portion of an ellipse. If we use the T1 to T12 model, the elliptical arc is 72 degrees. It's a 72-degree segment of a 90-degree quadrant. We have a B over A semi-minor over semi-major axis ratio of 0.69. The height over length index was 0.96. The ellipse's minor axis passes through the superior end plate of T12. The major axis is parallel to the posterior body margin of T12. Anterior and posterior vertebral body and disc heights are provided in the literature and in our subjects, and we found an average ratio of 5 to 1. We developed 4 different models based on different partitions of the best fit thoracic ellipse using different ratios of vertebral body to disc heights in the literature and in our subjects. We developed segmental angles and total angles, and these closely agree with normal values in the literature and in our 50 normal subjects. Thank you for your time and attention. Hopefully you enjoyed this particular project. If you would like more details on the mathematical analysis and the equations, I will refer you to that particular project, the methods section in the Spine 2003. For patients, we'd love you to go to a CBP trained chiropractor. Not all chiropractors do corrective care work. It's not good or bad, it's just they don't do it. If you're interested in corrective care, let's find a CBP trained chiropractor that can take a look at your spine radiographs and determine whether or not you're within normal limits. After all, everything in healthcare, everything has to compare you to normal databases to decide whether or not you are within normal limits and whether or not you are working correctly inside your body's natural biorhythms. Without a model, you cannot compare yourself to normal or abnormal. This model can determine whether or not you're within normal limits. CBP trained chiropractors know how to do that for you. Go to our website, cbppatient.com, and look one of them up in your area. I promise you, you won't be disappointed. For chiropractors out there that want to learn more about CBP technique, go to idealspine.com, look us up on the web, and also everybody, patients and chiropractors, please consider supporting our research efforts with CBP Nonprofit. You can do that directly by donations through PayPal at cbpnonprofit.com, or you can do it indirectly by going to Amazon Smile and just choosing Chiropractic BioPhysics Nonprofit as your nonprofit organization that you want to fund through your Amazon Smile purchases. Amazon Smile takes 0.5% of your purchases and donates it back to CBP Nonprofit. Again, thank you for your time and attention.